All right, good afternoon, everyone. I hope you are enjoying the summit. It is time for our next presentation, which will be on multi-state HIE partnerships. And we have a great panel with us today. We have Stephanie Brown from CRISP DC. We have Kyle Russell, who won't be able to attend in person, but he has a recording that we will share, and he's from VHI, or the Virginia HIE. And then we have Nichole Sweeney, who's our general counsel at CRISP and CRISP Shared Services. In this presentation, you will hear not only about CRISP's partnerships with other HIEs, you'll hear about CRISP Shared Services and learn more about what that entity is. You'll hear a little bit about TEFCA and national networks and how CRISP is operating through all of these partnerships. I will remind folks, if you guys have questions, please put them in the Q&A feature, and we will answer as we go along, and hopefully have time at the end to answer any questions that you have. And we are recording this session, and we will distribute both the recording and the slide deck to all attendees. So without further delay, I will turn it over to Stephanie, who will start our presentation on multi-state HIE partnerships. Stephanie.
Thanks, Kevin. Hello, everyone. Before we get started, I wanted to quickly introduce myself. My name is Stephanie Brown. I'm the Executive Director for CRISP DC. I've been in this position for a little over a year now, and I've been at CRISP DC for just over 3 years. I'm a public health professional by education and experience, and have found that really serves me well in this current position. I do have diverse work experience serving populations in Camden, New Jersey, Howard County, Maryland, Philadelphia, and now Washington, DC. I look forward to discussing the CSS model and how the work we do benefits all regions. All right, next slide, please. I wanted to start with a quick overview of the CRISP DC organization and our governance structure. Next slide. So a little bit about CRISP DC. We are a standalone corporation serving the District of Columbia, and we are designated by the Department of Healthcare Finance. CRISP DC is governed by our own board of directors with representation from organizations like MedStar, AmeriHealth, the DC Hospital Association, Johns Hopkins Sibley, Mary Center, the Federally Qualified Health Center, DC Health, which is the DC Department of Health, former Whitman Walker FQHC leadership, as well as ex officio representation from CRISP through Craig Bem. We also have a few other district hospitals like George Washington University Hospital as well. We also have our own clinical committee like CRISP Maryland and the other affiliates who approve appropriate use cases under our participation agreement. On the screen here, you can see the CRISP DC mission and vision, which was updated recently to include language that embodies our programmatic goals around providing data for the coordination of equitable whole person care. To talk a little bit historically, before the summer of 2022, CRISP DC was an LLC under the CRISP Maryland Corporation. That is how the CRISP DC organization was originally founded. But starting in the summer of 2022, CRISP DC was granted its 501c3 status by the IRS, which is very exciting, and we finalized our bylaws with the board, and we are now our own standalone corporation, functioning completely separately from CRISP Maryland. So you can think of CRISP DC just like West Virginia, Connecticut, what have you. All right, next slide, please. So I wanted to talk a little bit about the CSS model because it's very unique and it benefits all of the affiliates. And as an affiliate, I wanted to highlight some of those examples from another kind of partner's point of view today. Next slide, please. Before I get into the benefits of CSS, I wanted to talk a little bit about the structure. So here you can see all of the current affiliates and CSS participants. To be a CRISP Shared Services affiliate or participant, it basically means that you contract with CRISP Shared Services for certain IT infrastructure or other services like finance and people management, human resources. We have, as you can see here, CRISP in Maryland, West Virginia, Washington, D.C., Alaska, Connecticut, and most recently, Virginia. You'll be hearing from my counterpart, Kyle, next. We're very excited to have Virginia. I can say that Virginia was the most anticipated and requested partnership by DC stakeholders since my time here. I'm sure it's not a surprise, and many of you are probably also excited about them joining the CSS family. As we all know, in the DMV region, being from here and living here again now, I think we can all agree that it's very common for people to work, live, travel, and receive medical care across state lines in this region. This is what makes this regional model so important, but also the CRIS shared services model so important. All of the affiliates here share core infrastructure and are able to share that clinical data for patients who receive care, and one affiliate to all of the affiliates. So it's not limited to the data sharing in the state that you are located in, which allows for that continuation of care. All right, next slide, please. Here you can see some of the principles and benefits of affiliation, which begins with independence. And while number 2 highlights the benefits of that shared innovation across affiliates. While a huge benefit of affiliation with CRIS shared services is that shared innovation for the technology we offer, it's imperative that each corporation serving their state is able to respond to the specific needs of the populations that they serve. And then not only the populations they serve, but the providers and care team who are also serving that population, as well as the local government's needs who are the designating entity. Now, when it comes to reducing costs for all the regions through the shared services, innovation, and improvements of technology, this is certainly the most exciting part to this model, as each state and their funding sources allow for the sharing of innovation and best practices across affiliates. What this means is that each affiliate and their state partners can focus on innovation in certain areas, and then the other states who are CRIS shared services participants can use those products that were developed within the CRIS shared services infrastructure. This allows for the development of replicable models for programming within their own populations. And then sometimes the use case isn't completely replicable in that area. Then there's also the chance to build upon those tools that already exist to create additional features that make that product applicable to a new use case in your own region. This sharing of infrastructure and innovation creates a sustainable model for growth and allows all of the affiliates that participate in CRIS shared services to support, to remain responsive and competitive in the HIE market. Next slide, please. As highlighted in the previous slide, being responsive to local jurisdictions and serving patients in those regions is the priority of this model, and why CRIS DC is a champion of this model. Not only are shared services innovations funded through CSS model advantageous to each affiliate, but it's also the sharing of best practices and lessons learned amongst peers. The sharing of knowledge among partners benefits not only CRISP, but our stakeholders, our users, and most importantly, the patients that we all serve. Next slide, please. So specifically to you all, this audience of CRIS Maryland users, I wanted to wrap up by discussing the benefits to you of CRIS DC being an affiliate to CRIS shared services and partnering with all of the states that participate. Again, we all know patients receive care across state lines, and this model allows for the sharing of data in order to provide coordinated care. We have many health systems as well and ambulatory organizations that provide care both in Maryland and DC. And so that data is able to flow between DC and Maryland, creating that seamless workflow between organizations. To talk a little bit more about DC specifically, here you can see a graphic of the CRISP DC core capabilities for care team users. Some of these should look really familiar to you as they are part of the same core infrastructure that Maryland uses, but some of these are unique to DC and DC specific use cases, and I wanted to highlight a few of those before I end my presentation. So first I want to highlight is CRISP reporting services in DC. I know that you all have CRISP reporting services in CRISP Maryland as well, In DC, ours is a little bit different. We focus on creating reports that are focused on clinical population health, that have patient drill downs that the care team can then use to triage and manage their patient panel. Some examples of this could be hospital utilization, as well as filtering based on chronic conditions for population health programming at an organization. Second that I wanted to highlight was care management registries. We have two unique care management registries in the district. One of these would be absenteeism alerts. We partnered with DC Public Schools, and with explicit guardian consent, we get absenteeism alerts for DC Public School students that get sent to their care team. And then their care team and their care managers are able to reach out and assist those students and guardians who may need assistance. Second is lead registry data that we get from a district agency that allows us to assist them with lead registry testing regulations, and their care team to also kind of assist in that care management as well. Third is advanced care planning. So for advanced care planning, we have partnered with a vendor that allows us and some of our district users to single sign on from the CRIS platform to a platform that allows for the electronic documentation of some advanced care planning forms, specifically the DC EMOST form and a psychiatric advanced directive. Those are then stored in the cloud and retrievable through the HIE. The retrieval of those advanced care planning documents are available by all affiliates. So if someone thinks something is documented virtually in DC, a Maryland provider can then retrieve that advanced care planning document. And then lastly, as our social determinants of health work, I would say this is our largest work stream. This is something that certainly spans across the district borders into Maryland and other regions, as we really need to partner to support patients. And so through our SDOH work stream, we are working on a referral tool that is lightweight within CRISP for organizations that would like to make social needs referrals through the HIE. But we also have partnered with other vendors who are willing to share their referral data for partners they've already been working within CRISP. That way you can see those referrals and you can see those social needs organizations under care team within the CRISP platform. We also are partnering with the DC Primary Care Association and some of the organizations that they work with in order to create a community resource inventory that is specifically serving district patients. And then lastly is social determinants of health and social needs screening. We have a screening tool within CRISP that organizations can enter information into directly, but we also then can ingest that data from organizations to make that viewable at the point of care. Well, this is my last slide. Thank you all so much for having me, and I was excited to be able to share some information about the CRIS Shared Services model, how important that is for the district, and hopefully you can agree how important that is for CRISP in Maryland as well. Thank you.
Thanks, Stephanie. And like I mentioned, we have Kyle Russell, who is the executive director at VHI. He couldn't attend today, but we have a video recording that we will share, and just give me a moment to pull that up.
Hi, everyone. My name is Kyle Russell, and I am the CEO at Virginia Health Information, or VHI for short. We are the state health information exchange and health data organization for the Commonwealth of Virginia. And I'm happy to be speaking with you today as part of the CRISP Annual Summit to give you a little bit of our journey to becoming an affiliate of CSS for our HIE operations in the latter part of last year. So, as I mentioned, VHI really a much newer entrant to the HIE landscape, but we're an independent nonprofit, just like CRISP, that has been around for about 30 years. And so, really, you know, the kind of our bread and butter for a long time, or if you ask people what VHI does or how you know VHI, they probably would have said our website. They would say VHI is a transparency-based organization, and they are the consumer portal for how individuals can get information about a wide variety of healthcare topics that they might not be able to get elsewhere. And these are just a couple of different examples on the slides that maybe of some newer publications to give you a sense, but we were very focused on collecting data, not to provide at the point of service or something near real time, but really more focused on research and analytics. So think all payer claims database, think hospital discharge systems, things of that ilk. But times have changed through the years, and it just so happened, in the late 2010s, there was interest in reinvigorating the health information exchange in Virginia. And that was tied to a new program that the state wanted to launch that was later called the Emergency Department Care Coordination Program. And they wanted to house that within the Health Information Exchange, but they felt like they needed an organization that had been around for a while to really support that. And so VHI was asked to house that program and support some of the other different systems that the HIE was doing at the time, sort of on a trial basis to see how it went. And then we actually, it went pretty well. And then a couple of years later, we became the official Health Information Exchange in 2019. And so the organization has sort of shifted and focused and grown quite a bit over the past 30 years. So the scope of the HIE, it's certainly not on the scale of Maryland, but it has grown quite a bit. That EDCC system has really broad connectivity for all hospitals and plans. It's a really strong ENS system. And, there were a couple other highlights in some of the different programs that the HIE was administering that, VHI inherited at that time. And so really, the EDCC in Virginia meant kind of the rebirth or a strong foundation of maybe HIE 2.0 and how we move forward and kind of what we had put together over the first couple of years of its operation. But because we did a pretty good job and because the system was working pretty well, what happened a couple of years ago is that was noticed by the legislature, and VHI was asked to put together essentially a strategic assessment for how to take what was going well, the ENS, EDCC, and some of those other things, and say, well, what would it take to get from there to best in class? What are HIEs doing in other states that are more mature that we're not doing right now? And if we did it, it would add more value to all of our different constituents and healthcare delivery in the state as a whole. And so we were tasked with that to say, all right, where do we go next? And we looked at it and said, well, we're doing a pretty good job with EDCC, but we're not doing a heck of a lot with public health, right? That's definitely a weakness. And while we're really good at what we do, it does seem like there's a lot of other programs out there or things being done in other states that maybe we could do as well. And so the name that just kept coming up over and over again, like the recommendation to us is, well, hey, why don't you look at what they're doing in Maryland? Like CRISP is really like best in class at this. Like they're doing an amazing job. Like you should really model a lot of what you're doing after that. And so, we finally, had a chance to meet and talk between the few different states. And it just so happened that at the time at which we started talking with CRISP, that there was this offering we weren't aware of, which was the shared services infrastructure and program, and that a lot of other neighboring states were already doing this. And so you could, for how to take the state of Virginia to the next level, not only could you look at the best practices and expertise and all the public health infrastructure that was being done so well in Maryland, but you also could share in that with other states within your region or across the country. And so that made sense on a variety of different levels. It gave us expertise that would have been really hard to find elsewhere. It gives us a peace of mind that we're doing things consistently with states around us, and really opens up opportunity to make sure that our programs don't have to live and die at the state line. And just, for a variety of different sort of logistical and operational reasons, it just made so much sense, and it really aligned perfectly when we were being asked on how to take this to the next level. So it didn't take a whole heck of a lot of time before we determined, like, yes, this is absolutely the right move. This is where we need to, this is what we need to get to that in Virginia. And so really ever since then, you've been doing a little project after a little project. We're not in a situation where every single thing, like on day one, is changed over to CSS. But I would describe it maybe as a Venn diagram that's continuing, that middle part is getting bigger and bigger and bigger. And so we've already added a few projects. We have a really big one right now in our public health reporting pathway. And so I can't, sort of speak enough to how beneficial this has been for us. There's really nothing like it. And also how well received it's been by our stakeholders in Virginia, based on the reputation of CRISP and all the other affiliates, and just the overall concept, and just how much sense that makes, and how much it's viewed as really, really being part of the future. So we're incredibly appreciative for the opportunity to collaborate with all of our other state partners, and are very confident that will achieve great things together in the years to come. So thank you so much, and I'm sure you'll have a great rest of your summit.
All right, thanks, Kyle. We'll now turn it over to Nichole, who will talk a little bit more about the CRISP perspective.
Hi, everyone. This is Nichole Sweeney. I am the General Counsel and Chief Privacy Officer for CRISP in Maryland. I hold the same title for CRISP DC, as well as CRISP Shared Services, which Stephanie and Kyle both mentioned is the overall managed service organization that provides technical and other resources for HIEs and health data utilities to be able to effectively and efficiently execute, but still have local governance. So I'm really excited to be talking to you today. I'm going to be talking about HIE networks in general across the country, and specifically TEFCA. And if you're anything like me, by the time you get like 20 minutes into a presentation, you may have stopped paying attention. You might even be multitasking if you're human. So I try to start off my presentations with strange animal facts to get your attention again. And the one that's been on my mind recently is that owls don't have eyeballs. They have eye tubes or eye cylinders. I am scared to death of birds, and knowing this fact has made me even more scared to death just thinking about the fact that they have eye tubes. I don't even know what that means, but it was stuck in my head, and congratulations, now it's stuck in yours. So hopefully that got your attention because what I'm going to be talking about is a lot, probably less interesting than owls' eye cylinders. So today I'm going to be talking about TEFCA and how CRISP participates in larger national networks. So just to do some context setting, actually, before you go to the next slide, so I'm going to go back to the previous slide, Kevin, sorry. To do some context setting before we talk about what's called the national networks. What Kyle and Stephanie just spoke to are integrations with local HIEs and local HDUs, some of them not so local. But when we have integrations with these HIEs and health data utilities, we are able to share more robust data with them, and more robust data elements, and be able to do change information into, or data into information more rapidly, and be able to parse out data elements more rapidly as needed. So there is a difference between what Kyle and Stephanie talked about when we have those full integrations, or mostly full integrations, on our own tech stack, versus what we're talking about, what I'm going to be talking about, and that's the national networks, where we are connected to other national networks, other HIEs and health information networks across the country, but we are connected in such a way that we are querying for static documents, which I will get into a little bit more. So I think, the overall message from the three of us today is that CRISP works to make sure that we are connected to local jurisdictions and to the entire country to make sure that you all have the information that you need to make the right decisions for patients. And how we are connected varies, but we try to make sure that we get the information to you all. So with that, and I think my dog's about to bark, for which I apologize. You can go on to the next slide. Thanks, Kevin. So I'm going to be talking about TEFCA, and you have probably maybe heard TEFCA said before, or a couple of these acronyms. And I find that people, including myself, kind of like throw these around a lot, but don't ever fully explain them. So I thought it would be helpful before we talk about national networks, just to do some good old acronym definitions and to talk about this really from the ground up. So TEFCA is a government endorsed approach for a nationwide network of networks. So as I'll talk about in a little bit, what TEFCA envisions is already happening and has been happening for quite a while. So this is where sort of local hubs, you can kind of think of it as a hub and spoke model. And I have a visual later to talk about this, but there are hubs that call other hubs, so that if you are in Maryland and treating a patient that typically lives, I don't know, let's pick a state, in Indiana, and they come into your emergency room, that you could find out information about them, or vice versa. If you're a primary care physician and you have a patient that's vacationing in North Dakota, let's go with that, and they have an emergency, get treated in an emergency room there, that you would also be able to know what happened while they were there, so you could effectively treat them. So that's the idea of these national networks. There are these hubs that ping each other and query based on where a patient is, and where a patient is being treated. So that's been going on for quite a while now, and CRISP has been engaged in those national networks through eHealth Exchange and Care Quality. But over the past year, the TEFCA has been released by the Office of the National Coordinator for Health IT. And that is, so it's a national network that is, for the first time, government endorsed. All of the other national networks had sprung up because they saw a need, but there wasn't one that was coming from the federal government saying, this is something that we want you to get behind. So that's the context for TEFCA. And it's, again, just intended to ensure and enable interstate data exchange for specific what's called exchange purposes. And the idea there is that you can't just exchange data for the sake of exchanging data. You have to be able to say this is for the treatment of an individual, or for various other exchange purposes that are being launched in the future. Before I get into this, and I'll talk about this a little bit more, I do think it's important to say that TEFCA isn't a thing right now. Like, it is a concept, but it is not in operation. So I think that's important to remember. So that's TEFCA, and TEFCA is made up of two parts, the TEF and the CA. So the TEF, TEF, is the technical exchange framework, which is really a technology framework to say, if you're going to exchange data through these networks, these are the specifications that you should be using. This is the type of infrastructure that you should be using. And then the CA, the common agreement, is the agreement that folks enter into when they want to be a part of this national network, so that there are common rules of the road, common, actually, I say common because everybody has to agree to them, but very stringent privacy and security regulations, contractual agreements to make sure that everybody is on the same page. And because I said regulation and then I said, excuse me, I will take that as a second to say that this is not mandated. This is this is a voluntary framework. So folks can decide to take part in it or not. So another acronym you might hear is the Recognized Coordinating Entity, or the RCE. Though that is the overseeing body charged with making sure that TEFCA works and monitoring what's called the QHINs, and the QHINs are the Qualified Health Information Networks that connect directly to each other. So again, thinking about the hub model, these would be the major hubs that are talking to each other. And those would contract directly with the recognized coordinating entity. And then the QHINs would have could have participants, and the participants could have sub-participants and downstream participants. So it's this whole chain of folks that are then querying and sending data back through these QHINs. And then finally, if you hear SOP, that is standard operating procedure, which is probably an acronym you've heard before in the context of TEFCA. It is how it's connected to the various exchange purposes. So how you exchange and when and why you exchange data for treatment is going to be different than quality improvement. It's going to be different than individual access and public health. So even though there's a common agreement and rules of the road, there are various SOPs for exchange purposes, some of which are going to be mandatory. And initially that's treatment and individual access services, and some of which in the future will be something you can respond to, but don't necessarily have to. So again, this is all really being developed even as we speak. I actually am in a work group meeting right after this to talk about public health and TEFCA and how to make that SOP so that it's workable. So the takeaway from that is that, CRISP is very involved. The ONC is coming to us and saying, how do we do this? And can you be a part of these work groups? And we are still in the process of trying to figure out how all of this works. So those are the acronyms. If you hear me talk about them or other folks talk about them. On to the next slide. So I referenced this a couple of times. I'm going to repeat a lot of what I just said to make sure that the important points are heard more than once. So again, TEFCA is really just rules of the road for data sharing. If you have to remember one thing today, remember that. It is a contractual and operational framework. It's not a network or standards body. It's not a technology platform. It is not legally mandated. So again, the TEF is the operational and technology framework, and the CA is the contract. And then it is up to the QHINs to connect to one another through the common agreement. And then, as you see from the picture, the RCE is over the QHINs, and then each QHIN would have participants, and then those participants would have sub-participants, and so on and so forth. And the idea is that the QHIN, according to the common agreement, has to be able to support every SOP that we were talking about. So they have to be able to support provider exchange and pharmacy exchange and individual access and payers and providers, and public health authorities, but the participants themselves don't necessarily need to support all of those SOPs or return queries to those SOPs. So you might be a public health agency that is just using TEFCA for public health purposes, or a provider that's just using TEFCA for treatment purposes. But the idea is that that would all roll up to a QHIN in one place where you could exchange these data. Next slide. All right, I've said this a bunch of times, but I'm going to say it again because I think this is really important. And that is, TEFCA is really not new. Like the TEFCA itself is a new phrase. It is a new voluntary framework and common agreement. But the idea of a national network and a network of networks is something that has been around, and that CRISP Shared Services and CRISP have been involved in for quite a while. So this, when we saw TEFCA, we thought, okay, yeah, we know this. This is great. We know what to do here. This is something that we all should be doing. So this is really just the federal government sort of pushing people over the last mile, saying, if you haven't gotten on the national networks before, if you're not exchanging these data, you really should be. And again, it's not mandatory, but there's lots of incentives. But otherwise, the framework and the agreements are very, very, very similar. And in fact, as I'll talk about later, the DERSA, which is eHealth Exchange, Chris and Chris Shared Services have been exchanging data through for quite a while. And they are applying to be a QHIN. And so if they become a QHIN, we would be sharing data through TEFCA with eHealth Exchange. And again, that's something that we're already doing today. So there are some tiny new things and that are required by the Common Agreement that aren't by the DERSA, but for the most part, it's business as usual. All right, next slide. So then I just spent all this time telling you that it's really the same thing. We also want to point out, how it's different. And that is, again, as I talked about, it is government endorsed. And then the DERSA and the Care Quality Framework, both of which we are a part of, do have common agreements and rigorous technical standards. The ones in the TEFCA Common Agreement are much more rigorous. They're not crazy. Well, it depends on who you talk to, I guess. For national network, it's very important to have privacy and security requirements that are pretty rigorous. But these are more rigorous than the ones that we've seen in the past. It's really an evolution of those requirements. There's mandatory bidirectional exchange. So for some of the national networks, some things were mandatory. Again, in this case, there are going to be mandatory exchange purposes, specifically treatment and individual access, so that folks can grab their data, their individual data across providers from a consumer application or some other means that can connect as a QHIN participant. There's also going to be a mandatory push capability that is still sort of the SOP for that type of data is still in the works, but we will see that. And that is in contrast to a standard query where you put out a call and say like, hey, does anyone have anything about Nichole Sweeney out there? And then someone says, yeah, I have something about Nichole Sweeney. Instead of that, which is typical querying in a much faster electronic fashion, it would be if you have anything about Nichole Sweeney, you have to push it. And the way that is most likely going to play out is for public health mandatory reporting cases. But again, that's something that's still in the works. And then again, even though this isn't mandatory, we're seeing CMS and ONC push this framework by incentivizing through payment rules and information blocking exceptions and various other policy levers that they have for folks to participate in this. So those are really the differences. All right, next slide. So I will share that we recently, there was recently a health IT conference and someone was wearing a t-shirt that said QHINs aren't real. And we kind of had a giggle about it because they are real. It is a concept, but no QHINs actually exist yet. And I think that's something that's important to remember. And I said that at the beginning of this as well, that TEFCA is something that is still, is not yet in operation. So there have been several entities, including eHealth Exchange, which have applied to be QHINs. They are now, some of them, their application has been accepted. 6 organizations, I think it might actually be 7 now. I haven't updated this slide. I apologize for that. But 6 or 7 organizations, their applications have been accepted. That does not mean that they're QHINs. That means that the RCE looked at their applications and said, like, yes, as an initial look, it looks like you have everything that you might need to be a QHIN. Then they have to go through a technical, some technical tests, and then do onboarding. Then if everything works out, they would sign the agreement with the RCE and become a QHIN, and then they would start onboarding participants and sub-participants. So, the federal government has said it's important for them to get TEFCA going as soon as possible. There are still many steps between here and actually exchanging data, but it is something that is in the works. And again, it's for us, it's business as usual. So whenever it's whenever the light switch turns on, we'll be ready for it. All right, next slide. So a question I get a lot is, Nichole, if TEFCA exists and if national networks have existed for a long time, why do we have HIEs? Why is CRISP necessary? And I think that's a great question, and I'm going to explain that a little bit more in the next couple of slides. But I think it's important to know that TEFCA really was not intended to replace existing HIEs. It is intended to enable better data exchange between HIEs and to create those common rules of the road. But the value add that you're getting, that we hope you're getting from HIEs, not just seeing static documents from queries, which I'll show you an example of in a moment, but getting the information that you need in the way that you need it, in a way that is integrated in your workflow. Seeing things like CRS, which I think there was a presentation about earlier in some of our reporting services. We love TEFCA, we love national networks because we don't have to do that work. We don't have to connect with all of the other folks across the country. TEFCA is going to do that for us so that we can do the more innovative things, the things that are important to you all and important to patients. And if you go on to the next slide. And some of those things are, one of the things I like talking about a lot as an attorney is compliance with applicable laws. The more, and there was a question about this earlier, the more that I spend time in TEFCA work groups and talking to folks, the more I see this gap. There aren't rules about local privacy and security laws. It's going to be up to each of the participants to make sure that if Maryland has a specific privacy law that isn't a federal privacy law, but is very specific to the state, that Maryland entities aren't sharing data across QHINs. So that's why one of the reasons we feel that that HIEs and health data utilities are vital to this effort, so that we can be working with you all to be doing that local governance, to making sure that if data is particularly protected by Maryland state law, that we are ensuring that protection. And also that in the same way, we're working with other states to make sure that we don't get data elements that we shouldn't be based on those state laws. Another thing is the master patient index. And I think you all talked about that earlier today too. So don't quote me on this, although I am being taped, so I should be careful. But some of the statistics that I've seen are that over the national networks, if you aren't working with a local HIE, the return for particular patients is like 20% or less. Whereas if when you're working with CRISP, it's 90. Well, they never want us to give an exact, but it's like in the upper 90%. So being able to work with a local HIE that has the benefit of a master patient index means that when you query for Nichole Sweeney, you aren't just going to get an answer that says like, we don't have enough information about that person to know if this really is Nichole Sweeney. The HIE has done that work. There are going to be audit and enforcement mechanisms that we'll see coming through in the future. And then downstream data governance and usability. And that means, once data has been exchanged through TEFCA and it is a part of a specific QHIN or a specific participant, what can the participant do with that data? So that's going to be a question that is going to have to be continued to be answered. Next slide. And then, so how does CSS and CRISP fill these gaps? I've already talked about the local governance and privacy protections. We are also working more and more on implementing legislation that went through a couple years ago about a consent management application, which would allow patients to opt in or opt out based on specific data elements. This is becoming a bigger issue with reproductive data elements. And again, that's not something that TEFCA envisions. We already talked about patient matching. Public health is another huge area for similar reasons around privacy and security. What public health authorities are allowed to get differs based on the state. And so making sure that there are local governance bodies that understand what can public health officials get in Maryland? What are they entitled to get? What are they not entitled to get? We want to make sure that when TEFCA comes online, if folks are querying for public health, that they are, one, getting data. And if they are getting data, they're getting the data that they are entitled to get and no more and no less. Another thing that we think about for HIEs is equity and rural connections. So I did not say this before. I'm going to use this as an opportunity to say that QHINs, folks can only sign up to participate in TEFCA through one QHIN or one participant. So most of the EHRs have applied to be a QHIN, most of the major EHRs, and we are expecting that most of most of our participants will be will elect to participate in TEFCA through your EMR, your EHR. But there are many folks that aren't a part of EMRs and EHRs, and to get the incentives that CMS is giving for folks to connect to TEFCA, they need an on-ramp. And the same thing for public health agencies. Many of them don't have the same, most of them don't have the same capabilities in EHRs and EMRs, so they won't have a way to connect through TEFCA unless they have someone like an HIE who has worked through connectivity and the privacy and security requirements, and then can connect to a public health authority. There's also research, which TEFCA really doesn't talk about. So if folks want data for research, that's going to have to be done from a local governance and a local interested party perspective. And then, as we talked about before, data and analytics. Is it on my next slide? Yeah, Kevin, if you go to my next slide, this kind of reiterates the point a little bit. So what you're seeing in this slide is pretty close to what's going to be returned, and this is feel as a privacy officer, I have to say this is a test patient data. But what is returned is this type of static document. It's going to be, so far in the national networks, when you query for somebody, you are getting a whole document about them. You can't query for a specific data element or something like that. So to understand at a high level, what patients need the most care, you're going to need an entity like an HIE or an HDU to have the ability to turn those static documents into information, or turn the information that we have as an HIE into those analytics to be able to give you the information that you need, not just like hundreds and hundreds of static documents, but actually the data and information that you need. And I do think I want to say that in the future, there will be, the idea is like the nirvana state of interoperability. You will be able to query for specific data elements using the FHIR interoperability standard, but we're just not there yet. So until then, HIEs are going to be even more important. All right, next slide. And then a little bit more on public health, and this is really just saying what I've been saying for a while, is that we do anticipate that public health entities will be able to query for specific information in the future, rather than the static documents, which we showed in the last slide, but we're just not there yet. So it's so important for health information exchanges and health data utilities to work to make sure that we can do the normalization and translation of data, and to do that local governance to understand when the data can be shared and with whom and for what purposes. All right, so next slide, how do we participate in TEFCA? So through CRISP Shared Services, CRISP intends, and again, there are no QHINs, so we can't currently do this yet, but CRISP Shared Services intends to contract with eHealth Exchange, which again is a network that we already use. It's everyday business for us, to participate in to participate in TEFCA. And then in the future, we will be asking our participants, do you want to participate in TEFCA through us? And if participants do, there will be additional documentation. Again, we anticipate that very few of our participants will actually participate through us. Most of our participants will likely be participating through their EMRs and EHRs, but we want to make sure that we're an option for folks that don't have that option for the equity reasons that we discussed before. So if you don't have another pathway to TEFCA, we can be and are happy to be that pathway for you. And then I think something else that we just want to get across is that Chris Shared Services is not applying to be a QHIN. We have never intended from day one when the common agreement was issued. We really decided, I think that day, within that week, that it made more sense for us to enter into an agreement with folks that already do this so that we can focus on not on the pieces that other people can do, but on the gaps that HIEs need to be filling. All right, and then the final slide is just resources. If you have more questions about this, first of all, if you have more questions about this, if you can't tell, besides talking about weird animal facts, I love talking about national networks. I specifically love talking about national networks and local privacy concerns. That is sort of my my recent soapbox, and it's been really interesting to talk about with people. So if you have heard of TEFCA and want to hear more, or thinking about how your organization may intend to participate in it, please feel free to contact me directly. I love talking about this stuff, and as I often say, my family really appreciates it when I talk about it to someone besides them that's more interested. So please let me know. And we also have provided several resources on this slide, including some FAQs, which we developed that are largely from the talking points from this presentation. So if you can't remember what I said or don't want to remember what I said, they're on the FAQs, both the Chris Shared Services and TEFCA, and then how Chris specifically will be working with them. And then if you want to know more about the RCE, we linked to their page. We also link to the TEF and to the common agreement. With that, I'm happy to answer any questions, and also happy to provide my email address to answer questions offline.
Thanks, Nichole, and thanks, Stephanie, for your presentation. I also want to thank Kyle for providing the video in his section of this. Nichole, we did have one question that maybe you can answer. Someone writes, if CRISP is/has been exchanging data through TEFCA-like processes, can TINs that use CRISP report in MIPS or promoting interoperability that they exchange data through TEFCA instead of the HIE? We currently attest to that and get a letter from CRISP each year for our MIPS book of evidence.
Sure. So this is for, if I understand the question correctly, this is for the quality reporting program and how folks can get points to get payment through Medicare. And so one of the ways to get points is through the promoting interoperability point structure category. That's the word that I'm looking for. The category that the TEFCA incentive is don't quote me on this, but it's something like bi-directional exchange something. You can get those points either through working with an HIE or in the future with TEFCA. So you can do it in either way. My understanding is that there's going to be a very similar route through TEFCA as through the HIE. So, you can continue getting points either by working through CRISP or through TEFCA, but they both give you the same amount of points. You can't get like double points for them. Hopefully that answers the question.
Thank you. Someone asked, can you discuss various roles and positions of insurance companies? I think they may be referring to in national networks or in a TEFCA-like.
Sure. So insurance companies could definitely be participants. It's probably difficult. I'm speculating a little bit here. It's usually where I get in trouble. But it's probably difficult for them to be a QHIN because QHINs have to be able to respond for all the purposes including treatment and public health. And my guess is that most insurance companies wouldn't be able to do that, but they could be a participant and exchange data. You would have to exchange data. Everybody that participates has to exchange data if someone queries for a treatment purpose, or if a patient wants to get individual access to their data. And then my guess is that most insurance companies could choose to query and send data for payment purposes. I think it's important to know that if you are signed on and you can query, if somebody queries you, you have to send data if you can. So you can't just query, you have to do that bi-directional exchange. But I think that's mostly how insurance companies are going to be a part of it. And I know that there is an SOP for payment. I have not been involved in that one. And I don't believe, I know it's not something that's going to be required right away, but it is going to be something that is permitted. So insurance companies are definitely intended to be a part of this if they would like to be.
Awesome. And then our last question asked, is CRISP merging with TEFCA? And I pulled back up this CRISP involvement slide. I don't know if you want to.
Yeah, so yeah, I think just as an overall, there is no way for CRISP to merge with TEFCA because TEFCA is not a thing. It is a framework and an agreement. So we can be a part of it, we can share data with it, but there isn't a function where we could merge with it. But again, we'll be participating in it. We'll be sharing data like many other places. So, and if you have further questions on that, just let me know.